Hello and welcome to another live broadcast with MedStar Health. My name is Michelle Carter and I'm so glad you're here with us today. In recognition of Colon Cancer Awareness Month, we're taking time to talk about colorectal cancer, what it is, why screening and awareness matter, and how advances in treatment and surgery are improving outcomes for our patients. Did you know that colon cancer is the fourth common cancer in the US? The good news is that when it's detected early, it is highly treatable. Conversations like this can help raise awareness and encourage people to take charge of their health. So today we'll be discussing the journey from diagnosis to treatment, including risk factors, surgical innovations, and promising research that is shaping the future of colorectal cancer care. Whether you're a patient, a caregiver, clinician, or simply interested in learning more about your health, we're glad you're here. Keep watching, share this broadcast with your friends, give us a like to let us know that you're here. And if you have any questions, please share those in the comments below. All right, before we get started with our questions, I want to introduce our panel of experts, our colorectal cancer surgeons. I'll go around the room and you can meet them. We have Dr. Tushar Samdani, Dr. Marcus Usenbrug, Dr. Stephen Wexner, Dr. Sharif Shaki, and Dr. Ann Fabrizio. Thank you all for joining us today. Could you share a little bit about yourselves and the work you do here at MedStar Health? I'll start with Dr. Samdani.
Hi, I'm Dr. Tushar Samdani. I'm one of the colorectal surgeon with the group. I do mostly colorectal robotic colorectal surgery, cancer surgery, inflammatory bowel disease surgery, and mostly my practice is in Southern Maryland area, and I do surgeries in Georgetown area, Georgetown Hospital. So the practice encompasses benign as well as malignant colorectal problems, and that's what my specialty is.
Thank you. Thank you again for joining us today. Dr. Usenbrug.
Hi, my name is Dr. Osenbrug. I did my training in Canada before coming down to the US for fellowship at Cleveland Clinic, Florida, and then now here I'm at MedStar, primarily at Georgetown University Hospital. My practice is really the gamut of colorectal surgery, both benign, malignant disease. I do have a special interest in high-resolution anoscopy for screening for anal cancer as well.
All right, thank you. Thanks again. Dr. Stephen Wexner.
Hi, so I'm a recent addition to the MedStar Health System and happy to be here. I was at Cleveland Clinic, Florida for 38 years, most of that time as department chair and director of the Digestive Disease Center. I've served as president of American Society of Colorectal Surgeons, president of the American Board of Colorectal Surgery, president of the Society of American Gastrointestinal Endoscopic Surgeons, vice chair of the Board of Regents, the American College of Surgeons, and sundry other responsibilities. And I had the phenomenal opportunity to work with this outstanding group of individuals you're meeting today and others who are going to be participating in other Facebook events across the MedStar system in the role of physician executive director and system chief for colorectal surgery. So I'm really pleased to have this outstanding crew of surgeons working with me.
Absolutely. Thank you so much, Dr. Wexner, and welcome to MedStar. All right, turning to Dr. Sharif Shaki.
Hi, everyone. My name is Sharif Shaki. I'm a colorectal surgeon. I am also another addition to the MedStar Health amazing colorectal team. I started my journey in the US with in Cleveland Clinic, Florida, with Dr. Wexner. And then I continued to Cleveland Clinic, Ohio main campus as a fellow and as staff there, followed by Mayo Clinic. And then recently I just joined the MedStar Health team. I do benign and malignant colorectal disease. I have passion about this and is very happy to be here with you today.
Likewise. Thank you very much, Dr. Shaki. Now, Dr. Ann Fabrizio.
I'm Ann Fabrizio. I'm a colorectal surgeon who's based predominantly out of MedStar Georgetown University Hospital. I also see patients in Chevy Chase. I actually did my training at Georgetown for residency and then spent some time in Boston for further training and practice before coming back to the DC area and coming back to Georgetown. Like everyone else, we sort of practice the gamut of colorectal disease, focusing on minimally invasive disease robotics, and also reoperative surgery.
Awesome. Awesome. Thanks for Dr. Fabrizio. And thank you to our entire panel for taking the time to be with us today. So let's get started with a few questions, starting first with understanding what colorectal cancer is. So let's turn to Dr. Samdani. Could you give us the basics? What is colorectal cancer?
So in simple language, human body digestive system is stomach, small intestine, large intestine. Colon and rectum forms a part of large intestine. Colon is predominantly the longer part of the large intestine, and last few inches is rectum. When the lining of the rectum or colon starts growing abnormally, then it forms polyp mostly, and that polyp is not detected or not controlled or not resected by colonoscopy, then it becomes cancer. So this is the natural progression of colorectal cancer from normal mucosa to polyp to cancer. And the most important thing is we have to catch it early to prevent it to become cancer.
And how common is colorectal cancer?
So it is third or fourth commonest cause of cancer in United States. It is expected that annual incidence in 2026 would be around 160,000 cases of colorectal cancer. That means around 500 cases of colorectal cancer every day. So it is pretty common. Colorectal cancer is common, and the incidence is now increasing in younger population, which is a little bit concerning factor.
And what do you wish more people would pay attention to when it comes to colorectal cancer awareness or prevention?
So, right from it is, people generally think that colorectal cancer occurs in old age. It can occur in younger age. It depends on the symptoms. So, if you have altered bowel movements, weight loss, blood in stool, those are some of the signs of colorectal cancer. Also, at that time, they should talk to their primary care physician. They should talk to their gastroenterologist and think whether they are a suitable candidate for colonoscopy. People generally think young people or old people, if there's bleeding per rectum or blood in stool, what we call, then it's hemorrhoids and they get neglected sometimes. And I have seen many young patients who come to me as a colorectal cancer because initially they were disregarded or regarded as a hemorrhoid patient and they did not get colonoscopy.
Okay, so definitely that's where that early detection definitely comes in handy. So thank you very much, Dr. Samdani. Now I want to turn to Dr. Osenbrug and talk about the risk factors and the whole process of diagnosis um, and what increases people's chances of developing colorectal cancer. So Dr. Osenbrug, could you share what are the risk factors for colorectal cancer in general?
Yeah, it's a good question. So, when we think about risk factors, we divide them into two categories, both in terms of things that are modifiable and things that are not modifiable. Certain modifiable risk factors really are sort of lifestyle related things. Diet is a big one. Diets high in red meat, processed meat consumption, low fiber diet, and then overall health status. So things like heavy alcohol use, smoking, obesity, and physical activity are related to developing colorectal cancer. But then there's also the non-modifiable ones, which is advanced age. Age over 45 is really why we start screening at age 45 for most patients, as well as a personal history of polyps or inflammatory bowel disease, that's Crohn's disease, ulcerative colitis, family history of colorectal cancer, polyps as well too.
And do the risk factors vary by gender? And if so, what are those differences?
So the core risk factors are the same for men and women. We do know that men are diagnosed at slightly higher rates and tend to develop it at a younger age. We also do know that patients who have a history of uterine or ovarian cancer can signal potentially something called Lynch syndrome, which we'll talk about a little bit later on, which does elevate your colorectal cancer risk.
Okay, and could you share more about the genetics, the role that genetics play in colorectal cancer, and are there any specific genetic conditions associated with colorectal cancer?
hmm So roughly 20 to 30% of colorectal cancers have some sort of hereditary component to them, which is why we always ask about family history. About 5 to 10% are caused by what we say is a clearly identified inherited syndrome. So those are things like Lynch syndrome, but also different what we call polyposis syndromes that predispose patients to creating those polyps that Dr. Samdani mentioned, things like familial adenomatous polyposis syndrome, MAP, and serrated polyposis syndrome. There are a variety of them.
And we've been talking about colorectal cancer, but can you explain the difference between colorectal cancer and anal cancer?
Yeah, that's a one that comes up pretty frequently in the clinic. So, Dr. Samdani had mentioned the difference between, through the GI tract, between the small and large intestine, and the colon and rectum making up the large intestine. But the anal canal is actually the last 3 to 5 centimeters that lead to the external opening of the GI tract. And despite them being so anatomically close, they're actually fundamentally different diseases. We talk about colorectal cancer as being related to development of polyps and then adenocarcinoma, but anal cancer is something that's related to human papillomavirus or HPV infection, and is really treated entirely differently than colorectal cancer.
Okay. And are there any heightened risk factors for the LGBTQ community for colorectal or anal cancer?
The first one is, for colorectal cancer, the biological risk factors are the same as the general population. There are differences in anal cancer specifically. Rates are higher in men who have sex with men and HIV positive patients. But really, there's been a historical barrier to care in this population, and really sometimes even a mistrust of the medical field. So, all that to say is it's just important to find a provider that you feel comfortable talking to, bringing up these questions, and having open conversations about what can be personal topics because it can save lives.
Absolutely. That's very important, important point. Thank you, Dr. Osenbrug. Now I'd like to talk about treatment options. So let's shift to that. Treatment for colorectal cancer can vary depending on several factors, including the stage, tumor biology, and overall patient health. So Dr. Wexner, for someone who's been newly diagnosed, what are the primary factors that determine whether they will need surgery versus medical management, such as chemotherapy or radiation?
Well, the first determinant is the location. And as we heard a couple of times already, there's a difference between the colon and the rectum. When a tumor is in the colon, once in a while, it can be removed through a colonoscope, safely removed through a colonoscope. And in certain tumors in this day and age, perhaps 7% immunotherapy might be applicable for those lesions. But the vast majority of those patients will undergo surgery. The reason surgery is relatively straightforward is the section of colon can be removed and the two ends can be joined together. And there's not a consideration for having to wear a bag on a permanent basis. There's not a consideration of some other problems that can occur with rectal cancer. So that's colon. Rectum is a completely different entity for many reasons. It's in a very high-priced real estate area, as it were, because you have the vagina or the prostate, plus the bladder, plus the backbone, the pelvic side walls, the urine-carrying structures, the large vessels that supply blood to and bring it from the legs. So working down there is more limited. There's also the anal muscles. And depending on the relation to the muscles, that could potentially lead to a permanent bag. In these days, fortunately, far less frequently necessary than a couple of years back because of what you mentioned, chemotherapy and radiation therapy. So in this day and age, the majority of rectal cancers will end up getting chemotherapy and radiation therapy to downstage them, or in approximately a third of cases, to eradicate them so that the patient does not, as you mentioned, does not even need surgery.
That's good. I know patients are probably eager to find out whether or not surgery is actually needed, or if there's some methods, minimally invasive methods that can be used instead. So very good information about that.
A lot of minimally invasive methods, and the staff here, as you've heard from them, are expert in all of those methods: robotic, transanal, all of the latest and greatest technologies. And That's why patients should come to a center of excellence like MedStar Health, where we have our accreditation from the National Accreditation Program for Rectal Cancer because of our expertise in both diagnosis and management.
That's amazing. Amazing. Good to know. Dr. Wexner, what are the primary treatment options that are available today for someone who's been newly diagnosed for colorectal cancer?
Again, if it's colon, it's probably going to be surgical. It's probably going to be removal of a section of colon and joining the ends together. Little likelihood of a bag on the outside, not impossible, but generally no. If it's a rectal cancer, more often than not, after appropriate staging, which is with an MRI, the pelvis, a CAT scan of the chest, abdomen, pelvis, reviewing the biopsies, blood tests, and such. After that, and discussion at a multidisciplinary team conference, more likely than not, a combination of chemotherapy and radiation therapy is the starting point usually. There are some exceptions. Some tumors are removed transanally either by us or by gastroenterologists with different methods. And then if the patient is not a candidate for chemotherapy radiation because it's a very early lesion, straight to surgery, if that's the determination of the multidisciplinary team at the National Accreditation Program for Rectal Cancer Conference, or chemotherapy and radiation, and if the patient does not have complete resolution of the lesion, then going on to surgery, which is usually removal of the area with reconnection, and in this day and age, usually robotic or laparoscopic.
That's a good segue to my next question about how do you determine whether the patient should have chemo or radiation before surgery versus after surgery? And then could you also talk about total neoadjuvant adjuvant therapy, how it works, and whether it can replace their surgery altogether?
Yeah, so earlier on, Dr. Usenberg mentioned anal cancer, and back in the 1970s, there was a surgeon in Detroit who gave chemotherapy and radiation, and then when he removed the anus and rectum and gave patients colostomy, found out that the tumor disappeared, and that led to replacing surgery with colostomy to chemotherapy and radiation for anal cancer. In the 1990s in Sao Paulo, Brazil, another surgeon tried the same strategy for rectal cancer, and lo and behold, in roughly a third of patients, the tumor does completely disappear. It's evolved from some chemotherapy before and some after, with radiation before, to everything before, for the reason that you may get a complete response and everything may disappear. Secondarily, the chemotherapy seems to work better prior to than after surgery, and radiation is definitely, and it's not always necessary. There's some recent trials showing chemotherapy may be sufficient without radiation, but if radiation is given, it's much safer to do so to the prior to surgery, to the rectum that's going to be removed at surgery, rather than to the newly reconstructed neorectum after the native rectum is removed for the cancer cure and a reconnection done. So total neoadjuvant therapy is definitely employed in a large number of patients these days, and post-op radiation is rare, and even post-op chemo is getting very rare as well.
And how does genetic or biomarker testing of the tumor influence the patient's treatment plan?
Yeah, that's a great question, and our medical oncologists are getting very savvy with knowing, based upon those markers, which patient will respond to which agents or agents. So patients who we know won't respond are spared the potential morbidity of a treatment that's not going to work. 10 years ago, that wasn't the case. So the targeted therapies are really becoming the individual patient care pathways are really becoming the way to go. Much safer, higher probability of success. And if you are going to have complications, at least you're doing so knowing it's because there's a very high probability of success of the chemotherapy, rather than just sort of saying one size fits all.
Okay. And one more question. What role does immunotherapy play in treating colorectal cancer, particularly for stage 4 or metastatic cases?
Yeah, so that's something relatively new, and unfortunately, it's only useful in under 10% of cases. But in that 10% or under 10%, it's very dramatic. The tumors can completely disappear. Uh, my prediction is as time evolves, we'll come up with additional types of immunotherapy to treat additional mutations, genetic mutations, and we're going to have more patients offered that option and having complete response. But at the moment, it's unfortunately less than 1 in 10 patients going to be a candidate. In that group, it's highly efficacious.
That's great to hear. Thank you very much, Dr. Wexner. At this time, I'd like to pause and welcome our viewers again. Thank you to everyone taking out the time to watch this live stream. We're talking all about Colorectal Cancer Awareness Month in recognition of Colon Cancer Awareness Month. We're talking about screenings, risk factors, diagnosis, treatment options. So please keep watching, share this broadcast with your friends. Feel free to share any questions in the comments below. We have some time to answer those as well. Now I'd like to turn to Dr. Shalky and talk about recovery. So advances in surgery have significantly changed how colorectal cancer is treated and how quickly patients can recover. That's fortunate to hear. So Dr. Shalky, can you explain the difference between robotic, laparoscopic, and traditional open surgery for colorectal cancer?
Very good question. So unlike any other organ in the GI tract that lies inside the abdominal cavity, the colon and rectal surgery or colon and rectal anatomy requires the surgeon to interact or to work at least on 2 quadrants of the abdomen. So if we're dealing, for example, on the right side, we're dealing with the right lower quadrant and the right upper quadrant in order to mobilize appropriately the colon. And same on the left side. If we're dealing with rectum, we are dealing with 3 quadrants, the pelvis, the left lower, and the left upper. As you can see, dealing with these type of anatomical regions require a big abdominal incision in order to be able to execute the surgery properly. Minimal invasive surgery prevented that big incision by virtue of having small tubes that we insert through the skin, fat, and the muscle while the patient is asleep. We create a working space by insufflating gas inside the abdomen to basically make a tummy. And then when we make a tummy, we elevate the abdominal wall from the abdominal structures, the small bowel and the colon, so we can see. These ports, let's assume there are 3 or 4 ports, these small tubes. And through these small tubes, we have long shafted instruments. The hand is an outside and the tip goes all the way inside. With these different long-handed, long shaft instruments, there are going to be graspers that we can move things around. There will be scissors that we can cut things around. There are going to be energy devices that we can deal with blood vessels and so forth, and staplers. The laparoscopy and the robotic approach, or modalities, they lie under the title or the umbrella of minimal invasive approaches. So there is open approach, as I said, why we have to make a big incision. And there is a minimal invasive approach, which includes the laparoscopic modality and the robotic modality. The laparoscope, and they both use the same concept. Small tubes traverse the abdominal wall, so we can allow us to use long shafted instruments. The laparoscopy, the surgeon stands next to the patient on the operative table, and on one end, the surgeon is holding the instruments, and the other end, the instrument is inside. The robot is just a stand. The robot does not do the surgery. The robot is a stand, substitutes me as the surgeon, and that stand has 4 arms. These 4 arms, one end is connected to the robotic brain, and the other end has the working end tip. The surgeon in the robot surgery, in the robotic surgery platform, the surgeon sits on a console, look through binocular glasses, and can control the movement of the arms through that console. So that's the difference between laparoscopy and the robot. Laparoscopy, the surgeon stands next to the patient, holds the instruments himself or herself. Robotic, the patient sits on a console, and control the stand with the forearms, with the movements, but the surgeon does the surgery itself.
And what are some of the benefits of robotic surgery for colorectal cancer patients?
Very good question. So the minimal invasive surgery in general helped patients for faster recovery, less pain after surgery, therefore less narcotic need, and faster recovery, therefore faster return to their life style and their activities. So that impacted not only the hospital stay and making beds available for other patients who are in need, but it also helped the patient to have better recovery, better experience, and faster return to their lifestyle and their function.
That's awesome. That's great to hear. I have a question about the watch and wait method. So for rectal cancer patients, what is the watch and wait approach and who might be a good candidate for it?
Very good question. Recall of what Dr. Waxner explained about the current treatment of rectal cancer, which now is getting shifted from after surgery into giving chemotherapy and radiation therapy in hopes, because we know a certain number of cancer will basically evaporate with that. Therefore, if we find that there was a complete clinical response, meaning the tumor evaporated, and we confirm that by checking inside the lumen, inside the rectum, by doing colonoscopy and doing digital exam. And then we need to check if there's any residual of the tumor in the wall. And we do this by the MRI. And the MRI also will let us know if there's any residual tumor behind the rectal wall, like in the lymph glands, which is the basin of any immunity and cancer cells there. If we assure that there is no residual tumor, then this patient can go into wait, don't operate, watch, do regular screening every 3 months for the first 2 years, and then every 6 months until 5 years. Usually, the majority of the patients who will declare themselves that their cancer did not disappear will have evidence of tumor persistence or tumor recurrence within the first year to 2 years. The majority of the patients. So usually I tell my patients, if after 2.5, 3 years, there is no evidence of recurrence, rest assured, most likely the next 2 years are going to be fine. But we still ought to do it for a total of 5 years. So watch and wait. When the chemo and radiation therapy are provided before surgery, and the tumor proves to have evaporated, proved by no luminal disease, no residual wall disease, no residual mesenteric disease, the patient can hold off from surgery and go into a strict screening period for up to 5 years.
Okay, thank you for explaining that. And as we've mentioned before and throughout this live stream, treating colorectal cancer often involves a team approach, a team of experts, as we have here today with us. Dr. Shalky, could you share who are those specialists that make up the patient's care team? And also, how do you involve the patient in that treatment process?
Excellent. So there are two components for your question. There is the team that is involved in decision in the tailoring the plan, and there's a decision making which involves a shared decision making process, including the patient themselves. So the team that's involved in rectal and colon cancer treatment includes us, number one, colorectal surgeon. You need to confirm the identity or the characteristics of the disease. So you need a good pathologist, a dedicated GI pathologist. Okay. You will need imaging to characterize the tumor, the location and the status of the tumor, localized, regional, or metastatic. Therefore, you need a good radiologist, usually abdominal radiologist. Okay. And then you need to discuss the chemotherapy and the radiation therapy. So you need a good medical oncologist, dedicated medical oncologist, as well as dedicated radiation oncologist. Okay. And then I'm going to make a pause here. I would say, what if that tumor in the rectum, if you remember, Dr. Waxman said there are many organs that live nearby the rectum. What if this organ, for example, including the uterus, then you will need a gynecology-oncology partner to help with en-bloc resection of the tumor-involved organ, right? Or reconstructive radiology. So the tumor, or plastic surgery. So the team can actually enlarge according to the need of the patient. And all of these high caliber specialties are available at MedStar Health System. So this is the team that meets every week to discuss the cases and the patient needs. Now that this is translated to the patient by their main doctors. And this is where the shared decision-making process comes. The doctor explain the condition to the patient, educate them about what we have in the menu, and then guide the patient to choose the right decision for themselves.
I love that approach, making sure that all the people are coming together, having a meeting of the minds, if you will, to make sure that your approach is tailored to each individual patient. So that's from a patient perspective, as a patient of MedStar, that's really good to hear. So thank you very much for explaining that process. Many patients also worry about needing a colostomy bag. So what are the chances a patient will need one, and how often is it temporary versus permanent?
Okay, that's a very good question. Mashkan, I have to tell you, if it is colon cancer, very unlikely to have a colostomy or ileostomy. In certain rare occasions, when we feel that the restoration of the GI continuity is at risk of falling apart or breaking or separation at the suture line, sometimes we protect this, but not as before. It's very rare. That's for the colon cancer. So almost very, very rare occurrence. For the rectal cancer, we have to think of two things. Rectal cancer, operative, the most likely we do the surgery, remove the cancer, reconnect the colon with the piece of rectum above the anus or with the anus itself. And we have to protect that connection with a temporary diverting loop ileostomy, a bag from the small bowel. So we put the new reconstruction that we did out of function. We put it out of circuit because the stool is going to come out from the small bowel. It's not going to go through the colon until we make sure that that connection had healed. Because the sequela and the consequences of a break in that anastomosis or in that suture line is huge. So that's why we don't want to put the patient at risk. The diversion does not prevent the complication. The diversion minimizes the impact of the complication. Sounds good so far? Now, if the patient has a tumor that's involving the anal canal, like in the junction between the rectum and the anus, historically, these patients would get removal of the anus and the rectum and permanent colostomy bag. Nowadays, as you asked me before and asked Dr. Wexner and the rest of the team, we have the watch and wait. So we intentionally give these patients chemotherapy and radiation therapy upfront in hopes that their tumor will evaporate. If the tumor evaporates, then we do organ preservation. We don't do surgery at all. We just put them into that strict screening and surveillance pathway tract. If the tumor does not resolve, there are still technical things that we can do to prevent removing of the anus completely. If the tumor is superficially invading the sphincter, then we can dissect between the two sphincter muscles and save the whole thing. And now it's become very rare, but sometimes the tumor has invaded already the whole sphincter and we have to remove the anus. This is the only group of patients that will have to have permanent end colostomy.
Okay, thank you for explaining that, Dr. Shaki. Now I'd like to talk about quality of life and looking at life long term after diagnosis. So, Dr. Fabrizio, what do outcomes look like today for patients who are diagnosed with colorectal cancer?
So overall, survival has been improving over the last few decades with improvements in medications and technology. Unfortunately, it is still a cancer that can result in death. So it really depends on the stage of diagnosis. So that reinforces the importance of screening and catching these things early, because if you catch the cancer early and it's an early stage, the survival is actually quite good for colon cancer. It can be over 90% 5-year survival. And we look at 5-year survival because the first 5 years after your cancer diagnosis is really the time that cancers have the highest chance of coming back, typically in the first 2 years. And as you get further away from your treatment, the chances go down. So at about 5 years, that's sort of when we decrease our screenings and surveillance because the chances of cancers coming back at that point are quite low. Unfortunately, when people get diagnosed at a later stage, what we call stage 4 metastatic disease, the survival for that is still less than 20% at 5 years, unfortunately. But we are still, there are advances and a lot of trials and research going into how we can improve that.
Thank you very much. What does follow-up care look like once, the patient has finished treatment, and how do physicians monitor that reoccurrence? You alluded to it a little bit earlier, but what does that look like for patients?
Yeah, so it's a combination of things. So one of the most important things is frequent visits to the doctor, either your oncologist or your surgeon, sort of for physical exams and evaluations, and that happens quite frequently, especially initially after the end of treatment, and then starts to stretch out as you get further along in that 5-year period. There's also blood tests that are involved. So there's tumor markers that we can sort of track along with your treatment. So one of them is called a CEA, that's a tumor marker, and there's also circulating tumor DNA that more and more physicians are using as a marker for possible recurrence of cancer. And in addition to that, there's also imaging studies, so CAT scans that we look for evidence of disease coming back or spreading somewhere else. And then, of course, colonoscopy. So once you've been diagnosed with cancer, it's important that you continue to get those colonoscopies to make sure that you're not growing a cancer back or developing new polyps and developing a new cancer.
And now let's talk about those innovations that we've mentioned earlier, and also research. We know that they're constantly improving how we can diagnose and treat colorectal cancer. So Dr. Fabrizio, are there any clinical trials currently underway for colorectal cancer, and what are researchers studying?
So there's a lot of clinical trials out there. And if someone does get diagnosed with colorectal cancer, it is important to sort of reach out to your team of medical oncologist surgeons to see what you're a candidate for. Sort of grouping them into sort of large categories. The biggest one is really those medical therapies, so your chemotherapies. Like Dr. Wexler mentioned, immune therapy is sort of one of the newer aspects of medical treatment for cancers and has been shown to be very promising in patients that are candidates for that. So targeted therapy, immune therapy is sort of the next frontier that we've been seeing a lot of progress in. In addition to that, there's also clinical trials about novel surgical techniques, novel surgical devices. There are trials out there looking at avoiding that colostomy or that ileostomy with sort of devices that you can implant during the surgery. And there's also trials looking into sort of the patient experience of everything. So at MedStar, we are looking at how we can communicate with patients and in that post-operative period and recovery period to improve communication through the use of novel technology. So home devices that can communicate with patients and alert the physicians if there is a problem down the line.
That's very good to know, very reassuring as well. Are there any new treatments or innovations that patients should be aware of?
So the big thing is that targeted therapy again. So looking at the genetic profile of the tumor itself and basing our treatments on that. So looking at different combinations of treatments that could benefit. So we're looking at finding the most efficacy with the least side effects and complications.
And what do you think is on the horizon looking forward for treating colorectal cancer?
So it's really that personalized care and personalized to your specific cancer, your specific treatment. So looking at the genetic profile of each individual's cancer and looking at what targeted therapies, immune therapies there are, because if we can find a medication that is specifically targeted to the mutation that you have, the outcomes can be much, much better than if we were sort of, doing a non-specific treatment.
All right. Thank you very much, Dr. Fabrizio. At this time, we have a few audience questions that have come in. So, and thank you to all of you for tuning in and sharing your questions with us. Keep them coming. We have some time to address those. First, I want to turn to a question from Jennifer, from Jen. Let me go up to her question, and I'll address this to Dr. Fabrizio. She says her husband was just diagnosed with an 8 centimeter mass in his rectum. How do we know if surgery or radiation is best?
So it depends on the location of the tumor. So when we're sort of in what we define as the pelvis, so typically in the mid to lower rectum, closer to those sphincter muscles that we want to preserve, most often it's treated initially with chemotherapy and radiation. That does reduce the risk of cancer recurrence and gives people the opportunity for this complete response and potentially avoiding surgery altogether. So in those situations, it tends to be sort of the first line treatment. For patients with sort of cancers that are sort of the higher end of the rectum, so upper rectum, sort of within the abdominal cavity a little bit more, the risks of radiation tend to increase in terms of damage to other structures. So in those cases, surgery may be the first treatment.
Okay, thank you very much, Dr. Fabrizio. Thank you, Jen, for sharing your question. We wish you all the best for you and your husband as well. I have another question from Sandy. Also, I'll direct this to you, Dr. Fabrizio. Could you discuss the long-term effects of pelvic radiation for female patients in regard to any gynecological issues?
So it unfortunately has to do a lot with the proximity of the gynecological organs. The vagina sits right in front of the rectum, and unfortunately is an innocent bystander to when you get radiated. So complications of that can result in vaginal stenosis, scarring, decreased lubrication, and just anatomical changes in terms of how your vagina sits relative to everything else, especially if you undergo surgery. So those are all things that can potentially become problems, but there are ways to sort of manage that as well down the line. In addition to that, there are impacts to the nerves that run in the pelvis. So those can get damaged by radiation as well, which can impact our ability to have sexual pleasure and lubrication and other things as well, which is definitely something you should bring up with your physicians if you do experience that afterwards. That can improve over time, but sometimes it requires adjuncts like lubrication, medication to sort of help with those things. And we are looking at ways to sort of decrease the amount of radiation and amount of damage to areas. There is sort of the external beam radiation therapy, more targeted radiation. There's also proton beam radiation, which can decrease impacts to sort of surrounding structures as well.
Okay, thank you for explaining that. I have another question that I'll direct to the entire group. So, feel free to chime in as well to all of you. So this question comes from Christy. Are there any tips for the prep for surgery?
Should I take it?
Sure, Dr. Samdani.
Okay. Like for any colorectal cancer, this is a good question. Actually, every patient keeps on asking. First, you get a diagnosis of cancer, so family is already worried about it. It's a trauma, it's a shock. So I always tell patients that, and as the entire expert panel has said, that we have a lot of treatment options. So don't get worried. First thing is that we are here to treat you and help you. The other thing is this is a major surgery which takes place around 4 hours, 5 hours under anesthesia. Though we are doing it robotic right now or minimal invasive, though we need patient to be in optimal condition. So I always tell patient to do breathing exercises, maintain their nutrition, get that checkup, a preoperative checkup with their primary care physician, cardiologist. And those are the things which I want them to do before the surgery. And then there are tips regarding bowel prep, pre-op preparation for surgery, which we always tell them on the day before the surgery, what to do, what diet to be taken. And we also talk about what they have to do after the surgery. So those are the tips we start with, and there are specific tips for particular type of surgery. And as Dr. Shockey said about stoma, Dr. Wexner spoke about newer medications and treatment, and Dr. Fabrizio spoke about immunotherapy. All those things we talk to them about what preparation, what side effects can happen uh, based on where the disease is.
And when it comes to the bowel prep, I know it's not really a fun thing for anybody to do. Um, most of these patients have had a bowel prep before in preparation for the colonoscopy. So if that process did not go very well, some nausea, vomiting, there are a number of different types of bowel preps. So you can always ask to try a different one. Everyone's a little bit different in how they tolerate these medications. So there may be just a different type of bowel prep that may be easier on your system, or maybe sort of stretching it out over multiple days, which makes it easier for people. It is a lot of volume to consume at once. So if you do have concerns, bring it up with your physician, especially if you've had issues with other bowel preps in the past, because there are other options for that as well.
Thank you both, Dr. Samdani and Dr. Fabrizio. I have another question from the group. For the group, this one comes from Jen again. So this is about navigation for patients. So she's asking, how can we navigate through the red tape with insurance that slows down the process of seeing any required specialists?
So I think the most important thing is getting into at least one of the physicians first, and really once you start linked into sort of one of the members of this multidisciplinary team, it really helps facilitate everything else, because we're always coordinating behind the scenes as a group between our different services, and we can also help you and your family through that process of what needs to be done, and we can also communicate with the insurance companies as well. So we on our end will help sort of advocate for the patient and what needs to be done, so there aren't these big delays. I know it can be extremely frustrating when you get diagnosed with a cancer and then you can't get your imaging for another month. So once you get in with someone, from our end, we can sort of push the insurance companies and the radiologists to, let's expedite this. This needs to happen sooner. So we are working as a team to help you and your family through the process. So really finding someone to advocate for you. So if you can get that first appointment, that usually helps speed up everything else.
And
again, that's an advantage of being in a program that is Commission on Cancer, National Accreditation Program for Rectal Cancer, because the requirement is to have a coordinator who helps facilitate all of these appointments, expedites, and makes sure things are done in a timely fashion. But what Dr. Fabrizio said is really important, advocacy. And sometimes people have to start by advocating for themselves and saying to whoever made the diagnosis, look, I don't, just want to go down the street. This is my rectum. I'm trying to avoid a permanent colostomy and have the best quality of life and function. And I want to go to somebody who has true expertise, who works in a multidisciplinary team where I'm going to have the wisdom of the crowd participating in my care. You may only see 2 or 3 physicians, but there's perhaps 50 in the background reviewing all the particulars and ensuring that the treatment is the best possible treatment and done in the most timely manner.
Thank you very much, Dr. Fabrizio and Dr. Wexner. And our heart goes out to you again, Jen, and your husband. We wish you all the best in this process for getting treatment. At this time, we have a few more minutes. I just want to wrap up by getting your final takeaways for people who are watching. Perhaps they're a caretaker, perhaps they've been recently diagnosed, or they're going through that treatment. I'd like to get your feedback on what you would give, what advice you would give to patients and their loved ones who are going through this process. So I'll start with Dr. Wexner.
Well, the first thing to realize is that colon cancer is virtually certainly one of the only preventable cancers. And as I like to say, Benjamin Franklin said that an ounce of prevention is better than a pound of cure. And with colonoscopy, the lesions that were described by Dr. Samdani can be identified, the growths can be identified and removed before they become cancerous. So the best advice is get screened. And screening now starts at age 45, but colon cancer, colorectal cancer is now the #1 cause of cancer deaths in people under age 50. So any symptoms at all, bleeding, unexplained weight loss, abdominal pain, change in bowel habits, and any kind of family history of colorectal cancer or polyps should prompt that self advocacy and saying, hey, please think about screening me to one's physician, because it's preventable. And I think that's the most important thing. We can talk about cure all the time and talk about treatments, but the best thing is prevention. And we know how to prevent these cancers through colonoscopy. And that's what the month of March is all about. It's colorectal cancer awareness. And the awareness is that you don't have to suffer like this if you're getting screened in the vast majority of cases. So get screened.
Great words of advice. Make that appointment, people. Make that appointment, please. Great advice. Thank you very much, Dr. Waxner. Dr. Samdani.
So yeah, to add to that, like there are a lot of myths around colorectal cancer that it will occur only in old age, but we have spoken that as Dr. Wexner said, that the screening has become 45. There's 3% increase in colorectal cancer in younger population. There is another myth that it can only occur in if patients have family history. As Dr. Uzenberg pointed out, 75% are sporadic cancer. They don't have family history. You don't in older patient, you don't have to wait for symptoms before you get screened. So as Dr. Wexner said, get screened. And colonoscopy, as Dr. Fabrizio said, that the bowel prep is difficult and a problem. It's a lot to take on, but there are ways and means, and colonoscopy is going to prevent this and prevent the suffering and all those things and catch things earlier.
Thank you, Dr. Samdani. I'll turn to Dr. Osenbrug.
Yeah, we've been talking a lot about prevention, screening, which really is the core to preventing this very preventable cancer. We can catch it early. On the flip side of things, I think it can be very overwhelming the first time that a patient gets a diagnosis of colorectal cancer. Most people will sort of feel almost bombarded by information. Will leave the office and think, what just happened? I don't remember 95% of that. And I just want to say that is completely normal. But that's why it's a cancer journey with your provider. So, our doors are always open. We want to encourage ongoing communication. It's never going to be a one-time visit and then we're planning surgery and you'll never hear it. Any questions, write them down, come up, speak to us. And really, again, we're a multidisciplinary team, as everybody said beforehand. So each of those interactions with your care team are extra chances to ask those questions and make sure that you feel comfortable going into surgery or whatever part of treatment you end up getting.
Thank you, Dr. Osenbrug. I'll turn to Dr. Shockey.
I think I'm trying to find what other points I could tackle after what's been said. So I think one of the points that could be clarified is the bowel prep. I would think of it as following: friend it. Don't think of it as a challenge. Think of it as a mean to help you either clear your brain from any worries or concerns about having a cancer, or help the endoscopist to identify the precancerous, tumors, which are polyps, to remove them. Then you can have, can be rest assured and have peace of mind. So this is something that I wanted to share with the people. For the bowel prep itself, I would say this. I want to add a little bit of fun. So from personal experience, I would say get your bowel prep, get something to change the taste, like ginger ale or something, and get your best show, and just camp in your restroom, and you can watch your show. You can have your drinks, cold drinks, and it's just going to be 4 to 6 hours. But the best thing about prep, guys, is not really that you're having colonoscopy. The best thing is you feel amazing for the following 3 days after colonoscopy. And if you ask anybody who did the bowel prep, they will tell you that fact. You feel amazing in your tummy. So go ahead, book your screening, and enjoy the bowel prep.
That's one way to look at the bright side of things. Thank you very much for helping us shift the perspective, Dr. Shockey. Thank you very much for that. All right, and finally, last but not least, Dr. Fabrizio, any final words for our audience today?
So I think as you sort of go through the journey of dealing with cancer and the cancer diagnosis, aside from your medical team, there's also a lot of resources through like the Colorectal Cancer Alliance and other societies in terms of peer support, family support. So there in the DC area, there are multiple groups that help with that. So it's a different perspective. Being the patient, being a caregiver for a patient are completely different things than being the physician, obviously. And getting that different perspective of sort of what that journey looks like for people can be very helpful, especially when people who do require an ostomy. There are people who've been through that or are living with it, that and their experiences and tips can be extremely helpful. So not only in face-to-face peer support, but there's also online support. So if that's easier start for people to sort of broach the topic, there's a lot of ways to reach out to people who've been on this journey.
That's really good to hear that we have that support available for patients and their loved ones as well. So thank you so much to all of you. Thanks for tuning in. This wraps up our broadcast. We hope that you found this information useful. We really hope that you understand the importance and the urgency for getting those regular screenings to hopefully detect anything early and when it's in the process of being treatable. So thank you very much for tuning in today and sharing your questions and your feedback with us as well. I want to give a huge thank you to our panel of experts, our wonderful colorectal surgeons, Dr. Fabrizio, Dr. Osenbrug, Dr. Shockey, Dr. Samdani, and Dr. Wexner for taking the time to speak with us today and shed some light on a very, very important topic. Raising awareness about colorectal cancer and encouraging screening, highlighting the advances in treatment can truly save lives. So if you'd like to learn more about colorectal cancer screening, any treatment options, any more information, please visit our website. We'll share that in the comment section below. Thanks again and have a great rest of your day, everyone. Bye.
Thank you very much.